Good morning to all the midwives and to all the healthcare professionals and every doctor from everywhere that is joining us today. So today we are together to recognize and celebrate and elevate the essential role of midwives and healthcare professionals, doctors as frontline health workers. Midwives are not only skilled clinical professionals, they are educators, they are advocates, they are researchers, and they are leaders who work tirelessly to improve maternal and newborn health outcomes. Often, under incredibly challenging circumstances, I am sure you will agree. In many settings, particularly in rural and underserved areas, midwives are the primary and sometimes the only source of care for pregnant women and newborns. So their ability to act swiftly, compassionately, and with clinical precision can mean the difference between life and death. Yet, their contributions are often undervalued and under-supported. So today's webinar will highlight the ways that midwives and health professionals are leading change, not just at the bedside, but in policy, education, innovation, and system strengthening. We will hear from three incredible leaders who are each driving impact in powerful ways. So our leaders are Rebecca Motete, who is the president of SOMSA, our South African Midwives Association of South Africa, and Dr. Kaiser Baloyi, who is the head of the clinical department for obstetrics and gynecology in Limpopo, and then also Prof D Kaura, the head of midwifery and neonatal nursing at Stellenbosch University, whom we will all introduce as we progress with this webinar. As our speakers are sharing their knowledge and their slides, we do encourage you to type your questions in the question box for discussion later in this webinar. So this webinar is both a celebration, but also a call to action. It's about recognizing midwives, doctors, and healthcare professionals as the critical drivers of a health system and the transformation thereof, and understanding how we can better support them to catalyze change. So thank you for being here, and let's begin this powerful conversation. So first up, let me introduce Rebecca Motete, who is a midwife specialist and a deputy director of the district clinical specialist team in an area that I cannot pronounce, so I'm going to let her just pronounce that word, but she is from the Free State, and she is the president of the Society of Midwives South Africa and has presented the organization at the International Confederation of Midwives regional meetings as well. So with experience in national policy work, including serving on NCCEMD and Saving Babies technical team, Rebecca brings expertise in leadership, mentorship, and maternal care advocacy. Over to you, Rebecca.
Thank you so much, moderator. I'm from Limpopo.
That's it.
Yes. Next slide. My presentation is going to focus on the advocacy on policy change, the work that we have done in our district that went out throughout the whole province. Globally, when you look at postpartum hemorrhage, it is one of the leading causes of maternal deaths. And when we look at the maternal mortality ratio globally, it's 201 per 100,000 live births. In Colombia, it is 83 per 100,000 live births. And in South Africa, 119 per 100,000 live births. And we know that we are only left with 5 years. We are supposed to reach the SDG target of 70 per 100,000. Next slide. There is an early evidence of reducing maternal mortality with above 85% of success rate, use at lower level of care, and also use during transportation of patients. And this evidence has been found from the use of LRV. What is a challenge? Postpartum hemorrhage management has two main objectives. One, it is to stop the bleeding. It applies pressure. That's the LRV UBT applies pressure. Contract the uterus, uterotonics, and often number one objective is almost forgotten, stopping the bleeding. It increased the need for blood and blood products, which are scarce and very expensive resources. And it is also seen to be fatal, especially when a woman has got anemia. Mothers do pass away waiting for transport, during referral, lowest level of care, where there are no theaters, with mothers who are born before arrival, which are the home births. These are the challenges. Next slide. What is the impact? The impact is that loss of blood is a very valuable resource. Fathers and children are left motherless. Breastfeeding and malnutrition, infant mortality, we have depression that impact on our mental health as a society. The magnitude of the impact when we lose women from losing blood. Winning lives. The use of LRV-UBT included in postpartum hemorrhage management protocol, combination of treatment at all levels of healthcare, lowest level of healthcare. It can be utilized at the primary healthcare level, hospitals without treatment and specialists, at regional hospitals and tertiary hospitals. It can be used by specialists, medical officers, midwives, nurses.
Okay, thank you so much for taking me back into the webinar, and apology for that. The next one.
Hi, Rebecca. Unfortunately, Rebecca Motete is struggling with internet connection.
It is Africa.
It's unfortunately when you work in resource limited settings. She did communicate with us that if this does happen and she's unable to successfully reconnect, that she wants us to just please share her findings and the work that she's been doing in her district and what impact it has actually made. So I will humbly continue with her presentation. So what is the clinical and real life evidence? As we already know, clinical evidence on the LRV-UBT, it has been successful at all levels of care, being all the way from rural to tertiary hospital, it has been successful. When we were looking at implementation studies, it has been seen as a simple and sustainable intervention. When we're looking at comparative studies, it was the easiest, fastest, and simplest device to use. Other studies that support the use of a UBT, we can see it is recommended by the International Federation of Gynecology and Obstetricians to use not only for normal vaginal deliveries, but also during C-sections. It is a safe and effective intervention. And it looks like Rebecca is back, but unfortunately, it seems that her internet is a bit lagging. So we'll carry on. So if you are able to join, feel free anytime, Rebecca. So just to share her experience from South Africa, the LV UBT is used to strengthen PPH management. It decentralized the use of the LV UBT to all levels of healthcare. So no longer that you only needed to be at the tertiary hospitals, but even if you were in a rural setting, you were able to use an LV UBT for refractory PPH. So what Rebecca Motete did is that they actually advocated by introducing it. They advocated for advocacy and policy change, so it having been included into the policy. They ensured the availability of the LV-UBT. They did training and skill development. They did implementation and the rolling out and scaling. Right, Rebecca? Please continue. I see you are back.
Yes, I'm back. We implemented the LRV within my district that has got 6 birthing sites. We've got 1 regional hospital. So we took one step at a time around 2019 when the LRV was introduced, and we took an opportunity to do some case series so that we can be able to influence policy. So it was introduced, and we ran some trainings around the district, and we also did some case series. And with those case series, we were able to advocate for policy change, because that evidence, we were able to present it to our provincial PTC committee, where it was taken and it was put into policy that the LRV-UBT balloon tamponade must be made available. So the provincial office ensured the availability of the UBT, and we continued with our training and skill development, and we implemented it and we rolled it out throughout the province. Next slide. So with advocacy for use by midwives, South Africa having different levels of healthcare, like I indicated earlier, we transfer from lower level to high level of care, and every patient is different. Some may stop bleeding before transport, others continue to bleed during the next level of care. Due to uncertainty, many patients die during transit. The LRV-UBT has a T-valve step, which can simply be closed once uterus has tamponade, and patient safely transferred with uterus not losing any pressure. And in this trainings that we are doing, we also include our EMS colleagues, because from one facility to the other, they are the ones that are now taking care of the mother. So we teach them also on how to take care of the UBT tamponade, that it must be closed during transportation. So this led to revision of protocols, where inclusion of the LRV-UBT in the PPH management algorithm and protocols for both normal vaginal deliveries and cesarean sections was done. So here I'm just sharing the training sessions that we did around the district, and it also includes some slides from other districts within the province. And this LRV was made to be part of the PPH box. And our trainings, like I indicated, included medical officers, and we also include our EMS colleagues. And it is also part of an ESMO-E trainings, and even when we train the master trainers, we include the LRV. These are some of the testimonials within the country. One of the midwives said, our hospital record an average of 450 births, such as a busy unit in bound to encounter episode of postpartum hemorrhage. In 2019, we recorded a 0 death attribute to PPH, remarkable feat in comparison to previous years. Having the LRV UBT in our facility contributed to this in a small way. For us and for mothers under our care, it is a lifesaver. And one of the midwives there in a photo is a midwife from our facility, our district, Bongani Regional Hospital. She said, my experience using LRV, I found that it's easy to insert and user-friendly. The reason is because the first time I used it, I had never been trained, but I knew there was something called an LRV. I had to act fast and stop the bleeding. I just followed the instruction which are on the package, and it was easy to insert and the bleeding stopped. It's something that I would recommend midwives and doctors to use if indication allows to. With all the patients that I have seen where an LRV was used, the outcome was good if inserted correctly at the right time, not too late. Others are saying it is easy to use and has led to reduction of maternal mortality rate. The LRV is a time-effective device readily used and assembled ready. Like Dr. Baloyi said, we are from a condom catheter era. We are in an era of LRV, UBT, which is time-saving. So there you are seeing there's a helicopter there that is lifting one of the mothers from a regional hospital to a tertiary, our academic hospital where an LRV UBT was used. So here is a graph that is indicating the maternal mortality ratio from Liputso Health District since 2015-16. We started to use the LRV UBT in 2018-2019 financial year. You would see that we went down to 147.2, and then in 2020-21 the mortality went up. Remember, this was a season of a COVID season, so some of the deaths were COVID related. And in 2021-22 we went down to 134.6, and in 2022-23 we went to 105.7. So the big achievement was evidence in 2023-24, where we had the maternal mortality of 40.6, which was far beyond the SDG target. And in those deaths, there were no deaths related to PPH of mothers that gave birth in hospitals. We had one death of a mother that was born outside of the facility under a very strange circumstances when a root cause analysis was done. So that is the achievement that we had in 2023-24 financial year in the district. That's where we were sitting. So thumbs up to an LRV balloon tamponade because the deaths of PPH were reduced remarkably. So LRV is a she leaf. It's a life-saving device that is affordable, allowing for a widespread access to prevent maternal death. It is proven to be effective in all levels of healthcare, and most importantly, patient transfer. The LRV UBT is a device that must be present in all emergency trolleys and PPH boxes, and it must be used by midwives and nurse midwives. And the good thing is, like midwives are the first line responders in every emergencies. So every midwife must know how to use an LRV, and the resource must be made available at an easily accessible mode.
Thanks so
Thank-
much, Rebecca, for sharing that presentation. We are so glad that you were able to rejoin again. We were so glad that you were able, or that the connection was restored. Otherwise, we would not have heard that feedback, that transformation that you have seen in your district. So thank you so much for what you have done and for sharing your experience and also your steps of what you've done in order to accomplish it. Remember, if there is anyone listening and tuning in who has questions for our speakers, please type it in the Q&A box, and either the questions will be answered while we are presented, or it will be answered in the specific Q&A section.
You're
It seems
muted.
like we have lost our president from SOMSA. Let's maybe we can just continue. If you have any questions in the chat, then you can just leave your questions there in the chat box. If anything she has said, I see she was talking about winning lives, and from what I've heard, from what she has said in the past, like the LRV UBT has helped her or she's used it to drive the protocol change in her district. And she's seen the change, or she's seen a difference in winning lives at all levels of healthcare, lowest levels of healthcare, and hospitals without theaters and specialists, regionals and tertiary hospitals, and even if it's used by all other specialists. I see Rebecca is back. Rebecca, do you want to continue on this slide, or would you like to have the next slide? Rebecca, can you hear us? Okay, I think let us continue to our next speaker. We are having a technical difficulty on this first presentation, and we apologize for that, but we can continue to our next speaker, and we are very excited to listen to Dr. Kaiser Baloyi. If you will just allow me to introduce him. Rita has also told me a lot about him, and while she is getting her screen ready to share his presentation, I will do the introduction. So he is the head of the clinical department for obstetrics and gynecology in Limpopo province. Dr. Baloyi has been instrumental in transforming maternal care by leading the implementation of an innovative device, the LRV uterine balloon tamponade. It's a low-cost innovation to manage postpartum hemorrhage in resource-limited settings, and he will tell you all about Limpopo as one of these types of settings. His leadership has significantly reduced maternal death in the region, and especially in the remote and the rural communities. So Dr. Baloyi, over to you. Please share your knowledge with us. Thank you.
Thank you very much for that heartwarming introduction. May we go to the first slide? Next one. Yes. Next slide. Thank you very much. I feel grateful that I've been afforded the opportunity to lead the Department of Obstetrics and Gynecology in Limpopo. It hasn't been fashionable, or it is not fashionable to go to the most rural area, because one, it is very difficult to attract media. It is challenging to attract a business, and it is very, very difficult to just do anything. So these are challenges which we meet every day worldwide. And when you have to go to such an environment, or you are born in such an environment, or you were born and went to be educated somewhere else, gain skills, and you have to go back to your community to assist your community survive, to make sure that there is a next generation that is much better than you. It's quite a challenge. I was born here in Limpopo, and that is why I went to be educated in other provinces, which are better resourced than ours. I must also hasten to say that we have started the Department of Obstetrics and Gynae, the academic department, and therefore we have started graduating doctors, and now it's probably going to our fourth lot of doctors, and we're also training obstetricians, and we have graduated some obstetricians. Yes, it's still a single-digit number. We'll get to the double-digit number. Now, the reason for me to say this is for people to understand that we're working in a rural area that has had challenges and is still having challenges. And there is an indicator in terms of, if you want to improve health delivery or health services in a community, maternal death is one of the indicators. Now, we look at this Limpopo, and we see it's a big, vast province. So some hospitals are far away from the communities they serve, or communities are far away from those hospitals. And this, we're talking of good distance of about 100 to 400 kilometers from where they can get service. And this in itself, it's a risk factor in terms of a patient or mother dying, or any other patient who dies, who suffers any incident that leads to hemorrhage, be it a car accident, be it that you are stabbed, be it pregnancy related, which we are now concentrating on or focusing on today, that it's bleeding in pregnancy and eventually getting complications from that, including deaths. May I have the next slide? The maternal mortality in this province, compared to the other 8 provinces, South Africa is 9 provinces. The maternal mortality, or the mothers dying from while pregnant or during puerperium, was highest in my province, which is Limpopo. So comparing it to the other province, we're always sitting at number 8 or 9 in the highest number in the worst performing provinces. And this led to us coming with innovative means of attacking maternal deaths in a way that it should be able to reduce. Now, we looked at what we call preventable maternal deaths, and the leading index of what was causing preventable maternal death was maternal death from hemorrhage. Then we look at what are the causes of this hemorrhage in these mothers. Now, one of it, as you see on the sentence number 2, patients often travel long distances, up to 400 kilometers, and this takes a good 5 hours. If you have a patient with PPH, we know that you need a maximum of 30 minutes to be able to save them. Now, 400 kilometers can only be covered over a good 5 hours. So this is what will lead to patients bleeding, eventually dying en route while being transported to an institution which can handle their bleeding, or patients suffering complications, which we call morbidity. Complications like one, hypovolemic shock, they go into DIC, and then they will have irreversible kidney damage, and some of them will have brain hypoxia, and which will be irreversible. Next slide. Now, one of the innovative ways, and when we look at all this, we say, you know, Limpopo has got 5 districts. In each district, you've got what we call a regional hospital. And you've got 1 regional hospital and 6 district hospitals. So in the district hospitals, we don't have obstetricians, but we have trained midwives and doctors. However, there are complications which they can't manage. One of them, it is PPH, which they can manage, but if it doesn't respond, it may need that tertiary care or secondary care. Now, to travel to those hospitals has a good distance. So one of the ways was to recruit specialists into those regional hospitals, which is not a small feat. And to get that human resource, it's very difficult. And during that time, we only had specialists in the central hospitals, in the central hospital. And therefore, our regional hospitals were not effective insofar as managing postpartum hemorrhage, which fails the initial or temporizing management. So we had to get into a long-term solution, which is recruitment of specialists and improving the ambulance services. Now, we wanted the immediate solution. The immediate solution was, how do we temporize bleeding? How do we arrest bleeding while the patient is being transported to an institution where she will get definitive treatment? Now, for us to control the bleeding or even eventually stop it, we had to use tamponades. We had tamponades which were very expensive. And as a poor community, and I said that we, difficult to attract business here. So to get money from the private sector, getting funds from the government, it was difficult because we are poorly resourced, even as a government here. So we had balloon catheters that were not affordable to us. We resorted to using condoms, which will plug onto a drip giving set, and we put a veculator on it. And in some instances, it will work, but we had poor control on it. And, assembling all that, it was very difficult. Now, the difficulty of assembling that, and that it is not that reliable, and you wanted something that is readily available and affordable. And we came across the innovator. We innovated. We looked at simulating all this in an affordable way, and that's where the LRV balloon comes from, where it becomes a reliable tamponade device that is very, very affordable for a poor community like in my case. Next slide. Now, I've already delved into some of the solutions. Next slide. The solution being this LRV balloon. And when we found out, you know, we have an LRV balloon, and it's as effective as the tamponades that we couldn't afford, and it's easy to use than the balloons that we couldn't afford. Then we looked at LRV, and it was very, very affordable. So as an immediate intervention, we then organized seminars in which we promoted LRV as the preferred device of intervention in PPH patients and other modalities, of course, like the jackets and all this. However, the balloon comes in first with ease to use. And in most cases, we don't even have to use those emergency compressors because the LRV balloon has been so effective. So we ran all these workshops for the whole province. And from there, we went to all the districts, and the providers of this balloon also committed to a continuous training with us, training all the people in the province who are involved in the management of delivering patients. And this was a success. We saw the immediate success of it. Next slide. And this immediate success, next slide, please. I think I've already spoken about healthcare workers and the impact of that. The immediate success on this was immediately felt in the hospital. How did we feel it in our hospital as a referral hospital? One where we could spend days without having a patient with PPH in a compromised situation. The majority of them will arrive here with an LRV balloon, find that it has been effective. You don't even need any further management, further surgical management. Rather, we get blood, we further resuscitate them, and we eventually remove the balloon. And this will have saved a lot of blood, saved life, and saved the uterus, and saved other complications like kidney failure, the use of ICU. And, you know, that which would have costed us over and above a 500,000 rands came to be sorted out with a 200 rands. And that's a price. I'm not sure if it is still the price of LRV, but that's how big the difference is. And the manpower started feeling relieved. ICU was being relieved for other emergencies. Next slide. Now, my conclusion in this is that the impact of LRV balloon following the intense implementation or acquisition of the device, and intense implementation of it and follow up to it, within a space of 3 years, when we went, we had NCCMD releasing their results, which we had already felt the impact on. We were not surprised to find ourselves no longer sitting in the bottom 1 or 2, but we found ourselves sitting at the top of the ladder, being number 3 insofar as maternal deaths are concerned. And we became the bench. All the provinces came over to us for benchmarking. And LRV balloon was put across there as a game changer. And yes, of course, the commitment of the healthcare workers, as Sister Rebecca has said, that, you know, they get trained in early recognition of all these complications and therefore intervention. And that is my story for today. Thank you very much.
Thank you so much, Dr. Baloyi. I just want to say thank you so much for your hard work in Limpopo and making it available in Limpopo. We can see the hard work you've done to make it available and make that difference. So thank you so much for speaking today and sharing your experience on how the LV balloon has made a difference, as well as congratulations for moving Limpopo up from being the worst to being in the top 3. It shows you just how much of an impact it makes, making the product available for the healthcare workers to be able to use it, regardless of their location, being it a tertiary or a rural setting. So thank you so much, Dr. Baloyi.
So let me, without further ado, just introduce Prof Kaura, the head of midwifery and neonatal nursing at Stellenbosch University. She is our next speaker, and she holds a PhD in health informatics and has led national and international research focused on improving maternal and child health through innovative information systems. Her work emphasizes prevention and promotion in care, and she continues to mentor postgraduate students while still leading community health initiatives across the Western Cape. So thanks, Prof. Kaura, over to you.
Thank you very much, and thank you, colleagues, for that wonderful insight regarding what is happening in the clinical. One of the things that I really appreciate is the emergence of innovations such as balloon tamponade to give us solutions to what has been a challenge for a very long time. So what I'm discussing now is just how are we combating postpartum hemorrhage when we have had what Dr. Baloyi and Rebecca Motete have given us insight into the provinces. But that's from a clinical perspective. We also need to think about how much education can contribute to enabling the midwives while we are still in our setting. Next slide. So we've heard a lot that postpartum hemorrhage is the leading cause of maternal mortality globally. Whereas in Africa, when we think about maternal mortality rate, we're still falling about 70% of our maternal mortality rate of the world's global maternal mortality is in Africa. And according to the recent WHO data is that 14 million of cases of postpartum hemorrhage are also in Africa, are caused by maternal deaths are caused by postpartum hemorrhage. And with Africa having 70,000 of those deaths every month or so. So what are our barriers like we have had is that delayed recognition, inadequate supplies, and lack of trained staff, which we really need to honor, not just in the clinical setting, but within our education settings and especially in midwifery. Next slide. So UBT approach has been something that has excited me for the last 3 years, where we have now also integrated the emotive BADO, which has been approved by WHO and FIGO to improve outcomes. What does that mean? Emotive being examination, uterine massage, oxytocin, IV fluids, and tranexamic acid, IV fluids, and evaluation. But on the other hand, once we have done that, what is the intervention? It is the UBT approach, which has been something that we really we have been training in conjunction with the emotive approach. Next slide. Next slide. So what we have had is trying to educate the midwifery specialists. So our midwives have been core in doing that. But we want to implement and to scale up as quickly as possible. So how do we do that? Because we have known that the balloon device inserted in the uterus that we have seen is simple, it is cost effective, and it's life-saving. Dr. Baloyi has even shown us a real case study where you can save from millions of rands to just 100 bucks per woman. So if commercially a low-cost device like that could save us resources that are not even available, and the success rate is 80 to 9%, how can we scale it up as quickly as possible in order for us to support practice and in order for us to support our even few midwives that are in the clinical? Next slide. So the strategy that we started here is from evidence to bedside. How do we look at the midwives that are coming to the education setting? And with me, the midwives that I'm talking about is we have postgraduate programs such as emergency medicine, nursing, we have primary healthcare, we have midwifery, and we have intensive care. All these are people who deal with emergencies. So I took the initiative of saying that this is not just midwives. And I spoke to my colleagues and they said, we need this. And maybe we could also approach it with all other settings, that it's not just midwives who need it, because women are going to the emergency unit. Women are going to the primary healthcare setting because we have primary healthcare practitioners who are dealing with it. So maybe just the focus of in-service training to just midwives might not have reached everybody. So within our department, when we are doing the training of Ilavi UBT, we involve the primary healthcare students, we involve the emergency care students, we involve the operating theater students, and we also involve the midwives. And that's the basics of use of emotive and insertion of balloon tamponade. And I've been working hand in hand with SINAPI, where they've graciously provided us with those tools and also with the manpower to be able to ensure that each of these midwives are competent. So like this year, we have trained that group of people is about 150 within our program. So we would say at least 150 people will go out competent in the management of postpartum hemorrhage. So making it a standard standard within and integrating it within our programs has been very important. Next slides. So we will embed UBT into our routine care, and that's what our focus has been. The point of care where every midwife comes across a pregnant woman, we want to make sure that that midwife, that skilled birth attendant, whether it is in the basic antenatal clinic, whether it is in the community health center or tertiary or district or tertiary hospitals, they have an understanding of emotive bundle. So it's not just as a training event of clinical standard embedded in obstetric emergency, but also in any other facility that needs emergency response. So we were reflecting with the students on how to include emotive checklists in every delivery room, including integrating it in basic life support. Next slide. So the cascade training of using the train the trainer model was the next thing that we have introduced, where while we have trained every skilled birth attendant or every professional on how to use the balloon tamponade, the midwifery specialists are a category that is going back to change the policies and the protocols, but also they are educators within the clinical area. So what we have managed to do within our department is to integrate and train of trainer model. So they first do the introduction of insertion of balloon tamponade and emotive. Once they have been evaluated and they are found competent, then we now integrate the train of trainer model and collaboration with SINAPI, where they do a pre-test on understanding that, then they do the training and then a post-test. and it is a day's workshop that we do. But after the workshop, then they have a portfolio of evidence of training, which they will complete not just during the training, but even post-training. So the collaboration has been that during the training, I'll make sure they're competent before they go out. But while they are in the training, while they're doing the training, SINAPI is following them up to make on a hands-on training and retention of the people that we have trained to make sure that they're completing their training and their structures. So they leave with a certificate, but then they're followed through so that we can roll out in a structured way and make sure that we are rolling out competent midwives while they are training out there. Next slide. We want to reach every level of care. So last year we had a lot of students who were from the Northern Cape, and Northern Cape had been a challenge for the department, and they sent several students to me. And when they have left, I was so glad to see that they are actually implementing it with the SINAPI group. And SINAPI was gracious to give them training kits and with the hands-on practice, and because they had the experience that we had within here, they are able to be the global champions. They keep giving me feedback of how they are training, and they're getting a lot of good feedback from that outcome. So we need to have a sustainable change and local ownership. And for us to have local ownership is up to the branch level, up to the point of care, up to that dispensary or the clinic, the basic antenatal care clinic. We need to see people owning that leadership and taking that on in order for us to see the effective change that we are seeing. Next slide. So a trained midwife without tools is like a surgeon without a scalpel. We secure continuous supply of balloon devices, uterotonics, and tranexamic acid. But what I find challenging, and what my students have found challenging when they go back, because it's not just Northern Cape, I have Limpopo, I have Mpumalanga, and I have Eastern Cape, and I don't have much from KZN. But their challenges has been the supply from the Department of Health. And we're saying this is evidence. So why are we not rolling out enough supplies? How are we not developing kits and stocking up? We've realized that the accuracy of measurement of PPH is one of the things that has caused us to get to cascade to the end. And we have developed devices. SINAPI has developed just a very basic a drip that can help us measure the amount of blood. So why are we not giving this to every woman? It is her right. It's her right to receive the appropriate care. So those are some of the challenges that the people who are going back as PPH champions are facing. Next slide. So training without follow-up is not transformation. So pairing up new trainers with mentors and supportive supervisors. It's not really my role as an educator to do that, but it's also my role as a citizen to be able to take responsibility of what happens with women within our country. So when we decide that we are sending students out, we send them and attach them to somebody who can follow them up in order to ensure that there's transformation in that space where they have gone back. So we pair them with trainers who are already in those areas to support them while they're training other mentors, because we want effective competence and also confidence of the midwives who are training. So we also have monthly mentorship visits to assess skills retention and encourage use of emotive bundles and troubleshoot barriers, and that is in collaboration with SINAPI, to conduct real case reviews and postpartum hemorrhage events and learning opportunities. This is for the students who have gone as trained trainers and not necessarily the basic training that is happening. Next slide. We are not just teaching procedure, we are creating a system that consistently saves lives. And we believe that, because if we are just creating a machine that it's a factory of students, there's no effectiveness if we are not collaborating with the Department of Health and sending them back to Dr. Baloyi, and he doesn't know what these students are capable of doing. So one of the strategies that I would want to see in future is for us to think about, if PPH is one of the determinants of maternal mortality, have we taken it on board and said, we have a solution here? How can we effectively institutionalize and not just implement? So collaborate with our stakeholders, the departments of health, wherever they are, from the students that we have trained, and say, please support these students to be able to implement. And that is availability of supplies, availability of the balloon tamponade, availability of the things that are required. So I think this is a movement that needs to a strategic implementation, so that we are able to meet our goals and to have outcomes like we are hearing right now. Next slide, please. If you can't measure it, you can't improve it. So we need to be able to track percentage of postpartum cases where full emotive bundle has been implemented, and where our strategy for integrating train of trainer to within the university in order for us to see the change. So balloon tamponade has been shown to have success outcomes and knowledge scores pre and post training. We use dashboards and feedback loops to inform clinical quality improvements. And also we need to celebrate local success stories and motivate scale up. And that we are also doing currently. So it is a strategy that not just for us to start it's good for us to do for our performance, but we also need to be able to motivate scale up in all the other areas. Next slide. If you can't, challenges and lessons learned is that we need real world reflections that we've had today. The challenges of staff shortages is real. The high turnover, the inconsistent supply of balloons is a huge, huge challenge. We need lessons such as engaging with leadership, combining theory and simulation wherever we are to ensure that midwives are competent and confident in what they do. In-service basic midwifery refreshers, critical course. We need to integrate some of this training within our courses so that we don't, I prefer the courses to be able to be sufficient enough, because getting in people from the clinical to get in service is very difficult. So why don't we send out a holistic midwife who has all these skills, and she becomes a champion and a supporter in refresher training and follow-up. And that is one of the goals and lessons that we have learned. Next slide. Policy and advocacy, from training to transformation. We need to institutionalize PPH protocols within provincial and national. And we also need to advocate for emotive integration in pre-service curricula. We need procurement of balloon tamponades and kits and essential supplies to support the midwives that we have so much trained and sent them out there, and inclusion of PPH bundles in routine monitoring systems. Next slide. So in conclusion, every delay costs a life, and we need to act now. PPH is a preventable death. So if we have proven solutions, if we have TO2 models or train-of-trainer models that empower local systems to sustain gains, then we should be winning. So let's commit to training all providers, ensuring availability of tools, and sustaining through local ownership. The time to act is now, and we cannot afford to lose these mothers anymore. We have seen that it is effective, there is evidence, so why not use the same? Thank you very much. I think that's my last slide, and thank you.
Thank you so much, Prof. Kaura. It's absolutely a pleasure to have you today talking about the training, and we've learned a lot, especially on how you're implementing the training and teaching not only the midwives, but various healthcare providers on the systems and how to integrate it in the different levels. So thank you so much. So we have a few questions. I'm going to do the Q&A today. So I'm just going to exit here. And we'll go to questions. So what we're going to do is we're going to read the questions that came up in the chat, as well as a few questions what came up with the presentation. So firstly, I want to say absolutely thank you for everyone who's posted their questions in the Q&A. If you have anything you still want to ask, feel free to quickly include it at the moment, that we can still ask your question to our lovely panelists that graced us today with the webinar. Firstly, thank you for Takela from Ethiopia, who's gave a shout out to say thank you for this webinar, especially getting all this information. They found that it was found that the LVUBT, it is a simple and completes that emotive bundle approach. Okay, next a question is, I would like to know what is the cost of the production and purchase of the LV, seeing how the donor landscape is becoming unreliable for low-income countries. How sustainable is it on the market for other countries to purchase the LV? This question I'm going to give to Temke. She'll answer this.
Thank you very much for the question, Chinsisi. So the production and purchase or the cost of the LRV-UBT is quite simple. It's one of the most affordable devices. I think that is one of the words you've heard a lot today. So you are talking about a donor landscape. It is, however, available on the UNICEF product catalog at $17.01 in comparison to your other commercially available devices. That is 1/20th of the device price. So in South Africa, we can double check if you reach out to us. I'm going to share a screen shortly where you will be able to see all our contact details, and you can reach out directly, and they will share with you a quote that will be in South African rands, and we will also be able to share you the price in dollars as well. I want to add something. I see that the question also includes a second part where it's asking about the sustainability on the market in other countries that purchase LRV-UBT. So if you listen to what our speakers had said today, Dr. Baloyi, Rebecca Motete, and Prof. Kaura, they've all shared different facets of how to make innovations like these available. Everything from policy change, where you need to start from the top and then also scale it down, making it available, and then ensuring training and implementation for the rollout. And we are seeing the same being done in other countries, where they are starting at policy level with key opinion leaders, with policy makers, to start changing the guidelines there, to start implementing something from the top down, and then ensuring availability, getting different partners on board and rolling it out on a national level. So maybe starting in 8 provinces and scaling it down from there. We know of one of the countries we are absolutely seeing this happening in right now is Benin, where their Ministry of Health has taken the decision to include this device into their health management system. It started from the top with policy change, scaling it down, training all the healthcare professionals, and now making it available in all the different facilities, from your teaching hospitals all the way down to your rural care settings for public and private. So it is absolutely possible if you follow the different and various steps that has been discussed in these different presentations today.
Wonderful. I'm just seeing more questions rolling in. Okay, so our next question is from Anonymous. It says, Prof. Kaura and Dr. Baloyi, with regards to the motive study and your application at the hospitals in your region, at which volume of blood loss with PPH do you start the PPH protocol? As Prof. Kaura has been does trainer of training, would you mind answering this question?
Yes, and I think I'll do it in collaboration with Dr. Baloyi, because I'm sure they have been measuring. Now, what I wanted to mention is, apart from emotive and insertion of balloon tamponade, we have a drape that was also developed by Sanapi to be able to effectively measure the amount of blood. Remember, anything greater than 500 mils is seen as PPH. Now, if you want to measure 500 mils with your eye, I don't know how accurate that is. So we've gone to the level where we have different devices that have been implemented previously. Others would measure it with kidney dishes, and that is collection of the clots. And that is one of the reasons why we are not able to manage PPH early, because we underestimate the blood loss. So 500 mils is when you have accurately measured it. And we have, if you go into the training, you would see the drape that I would be talking about. Dr. Baloyi maybe can give us insight as how they are doing the measuring within the province.
Yeah, thank you. We are actually in the process of being accurate, and the only way is to, yes, use the drape, the synaptic drape, and that is the few that they gave us, which we have used, has been able to demonstrate even to our principals, so that this motivation eventually should be able to get to the procurement, what they call them, the procurement process of this, so that you become more accurate. If you're not accurate, what I see as 500 mils, somebody might think is 200. And in patients that have complicated before, we find that actually it was because of underestimation. And people only react when the BP drops. And by that time, that is late, because you see, your pulse first goes up. And if you're not in a monitor and you are doing it intermittent, your blood, your vitals are intermittent, you're not on a continuous monitoring, they only see it when the BP drops to say, it looks like she has bled a lot, or when she passes out. So, yes, the number 500 is what we use as PPH. But at all material times is that if you are still going there to that 500, if you are measuring live, which means you'll be using your that collection bag, which has got a live measurement on it, you will be able to pick up that, hey, now I'm 200, 300, it means I'm going too quick towards 500. And you start being active. So you will be more proactive if you are on that drape, and that will assist in preventing PPH. Remember, we don't want to save PPHs. The most important thing is to prevent them. That will be the most greatest important thing if we can achieve that. Like, when we go to theater, we take a baby for a cesarean section for fetal distress. And the anesthetist say, when the baby comes up with good abgas, they say, no, it was not a fetal distress, it's a good abgas. We say, yeah, we become happy. It means we were proactive when the signs were still coming. So
Thank
that's
you
the
so much,
same.
Dr. Baloyi.
Thank you very much.
Apologies. Unfortunately, we do have a time limit, and we absolutely appreciate you sharing your wealth of knowledge. But I fear you have so much, we might stay here much longer than we have time for. So, unfortunately, because we do have a bit of a time limit, I'm going to ask one more question for Rebecca Motete, and then we're also going to share a slide with you on this webinar, because there's so many people requesting, where can I get my TOT training, or where can I get my LV, UBT, or DRAPE? So a slide's going to come up in regards to how to get it, how to contact us. Please feel free, because you can get that anywhere in Africa or in South Africa. Feel free to contact us on that. So Rebecca Motete, as the president of SOMSA, we have questions here about, can midwives and nurses use the LV UBT when treating PPH? Are they sufficiently skilled to use this product and also treat PPH?
Yes, like I said earlier, that we are the first line responders of any crisis situation. They can use it, and training is provided, and mentorship is provided for them to can be able to use it appropriately. So with confidence, yes, they can use it.
Can I add something there, Rita?
Yes, please do.
In addition, because I see there was a question, I don't want to cause confusion. When we say we are training nurses, these are postgraduate nurses. And when we take our postgraduate nurses, they have to have midwifery. So one of the requirements is that you have to have midwifery. If you're doing emergency nursing, if you're doing primary health care, if you're doing operating room nursing. So when we are training them to use UBT, so they have an understanding of nursing. And I needed to make that clarity. I mean, midwifery, sorry. Thank you.
Thank you so much. Thank you so much to Prof Kaura, Rebecca Motete, and Dr. Baloyi, as well as my colleague Temke, for joining today at this for today's webinar. As we unfortunately already ran out of time, I just want to say once again, thank you so much for our presenters, for your wealth of knowledge in regards to on advocacy, on making the products available, and the importance of training. So feel free to contact us. As you can see, there is a lot of contact information. Feel free to contact me and Temke if you're in other African countries, so not just West Africa, because I see there's also Malawi requesting. Please contact Temke's email address at the bottom, or you can do mine. I'm also for Limpopo, but I also do Central Africa. Please feel free to contact us. We are here to help, and we are wishing you a great day further. Temke, do you have any further words?
Thanks so much, Rita. So we are extremely happy for everyone that joined us today. Thank you very much for joining this webinar. Please inquire for the purchasing of our products or for the training of trainings. We do see that in the chat. So for your Gauteng, Eastern Cape, Western Province, you can contact our representative there, Ms. Candice Williams. Her telephone number is on the screen. For all West African countries or your French-speaking countries, you can contact Uptake, who is our West African and French representative. For Free State and Northwest, you can contact Mariki. Her email address and numbers on the screen as well. KwaZulu-Natal and Mpumalanga, you can contact Sneshlanshla, and her telephone number is there as well. Of course, you can always reach out to either Rita or myself. We are happy to help, and we are happy to assist you with any other questions you may have. Then that is the end of today. Just a big thanks again to all our speakers. Thank you, Prof Kaura, for your time. Thank you, Dr. Baloyi, for your time, and Rebecca for joining us, even with technical difficulties. I know that not all of us are in high resource settings. Some of us are joining from low resource settings, and we appreciate what you are doing. We always hear in all the countries that we support, when you don't have anything, you work with what you've got and you make it work. And it's such a testimony to see that with technical difficulties, with challenges we have, we still find a way to make it work, because what we do is not just an everyday type of thing. It is saving lives. It is working with someone's life and making sure that you are saving a destiny at the end of the day. So thanks so much for all your efforts. It brings us to the end of our webinar. Feel free to reach out to us. And with that being said, we now conclude. Thank you very much.